Hello, everybody. Welcome back to Diversion Insights. My guest today is Brennan Luke. Brennan is the Regulatory and Controlled Substance Pharmacy Manager at ECU Health. Welcome, Brennan.
Thanks, Terri. Thanks for having me on.
It's good to have you. Let's start with a little bit about you and how you came into this type of work. Typically, diversion prevention isn't usually something people set out to do. It tends to find you. So take us back to the beginning and how you first became involved in diversion prevention work.
Sure. No problem. So I've been in healthcare for over 20 years, say 23 years now, and most recently as a pharmacist. And I think, diversion prevention, every pharmacist at least has some sort of awareness of that because we're always verifying orders and we're making sure stuff's legit. If not for diversion prevention reasons, also patient safety, which, those two things go very much hand in hand in my mind and in a lot of people's mind. So, always looking out for abnormal orders or unusual orders in the retail setting or even in the hospital setting where I've most recently been. And then we had a pretty, significant event at one of my health systems that I worked at. And there became a much greater need for more monitoring, for more auditing, stuff like that, some of the common diversion prevention and detection practices. So that's how I got my foot in the door. And that was also, I was just I was a bench pharmacist at the time. And this was kind of like more of an ancillary role or, something I could do in my off time. I worked overnight, so I had a little bit of downtime. While most of the patients were sleeping. And it was kind of like a pet project, if you will. So that's how I got my foot in the door. Then I became aware of a full-time role at another health system. Actually, some of the leaders that I had previously worked with identified that, hey, this guy might not be bad at this, might have kind of a natural aptitude towards this. Both my parents, actually, my mom, my dad, and my stepmom are all pharmacists. My grandfather was a pharmacist. So it's kind of our family tradition, if you will.
Yeah.
So kind of, keeping patients safe, the whole role of pharmacy is kind of in my blood, if you will. And so I got recruited to a full-time role doing diversion prevention and detection for a 3-hospital health system. And that was where that was a full-time gig. That was the only thing I did. I wasn't no longer doing routine pharmacy activities, strictly operational, strictly diversion prevention and detection. And that was my last health system. And now, like, as you mentioned, I'm most recently at ECU Health, doing a similar role, the regulatory controlled substance management.
Yeah. So the first hospital that hired you on full time to do it, did they have an incident that made them realize, or did they already have a program and you just built upon it? What was the situation there?
They had a very infantile program. There was I had a predecessor that was working for one of the 3 hospitals in the health system. But it quickly, once I got hired into that role, I realized that, if we're doing this at one hospital, why are we not doing it at all 3 hospitals? These problems are not unique to any one hospital in America, and we should be monitoring and, preventing diversion everywhere. So it quickly became a systemized role. And we grew it from there. Lots of growing pains, in the beginning, because unfortunately, this isn't really, there's no months advanced practice rotation for diversion prevention. There might be in the future as it grows and as it becomes more front of mind to pharmacy leaders. But when I went through pharmacy school almost 16 years ago, now over 16 years ago now, that this was kind of just something that we did on the side. It wasn't a full-time role, if you will.
Right. Yeah. Well, and even you had said in your introduction that all pharmacists play a role.
Yes.
I am still amazed, though, at how many pharmacists don't really think about diversion as something. I think maybe on the patient side, right, is from a retail perspective or patients trying to get access to meds. But I still don't think a lot of them internalize it from the healthcare professional side, from the inside.
I agree.
Yeah.
And it's not just pharmacists. I think it's all healthcare professionals because
100%.
Most of us get into healthcare because we care about people and we care about helping. and it's a rewarding job, at times heartbreaking, but rewarding on the whole. So we don't give the credit that, hey, some of these people got into it for ulterior motives, or, maybe didn't get into it for those motives, but after years of difficult work and heartbreaking, as I mentioned, maybe, led to substance abuse disorders and stuff like that. So, we like to think the best of our colleagues, our trusted colleagues. And I've been a victim of that myself. I've had friends and colleagues that had diversion issues or substance use disorder issues, right alongside me. And it's eye opening and it's heartbreaking, like I said, to work with people and they're diverting narcotics or controlled substances right beside you,
Yeah, definitely. I have found in my experience with multiple conversations with people in recovery is I feel like it kind of starts in two different buckets. One is they may be even critical of those who have a substance use disorder, but they have that propensity themselves. And once they're exposed to it, then off they go and they realize that, wow, I really like this. And it's out of their control. And then the other bucket are the ones that maybe part of them knew it, but they've struggled or they have an issue with alcohol, right? It's they partied too much. It wasn't just a party thing going through college or high school or what have you, that it actually was becoming more of a crutch. And then it moved from alcohol to something else because they already had that substance use disorder, but with alcohol, thinking it was just, I just like to party on the weekends, that then becomes more and more.
Yeah. And sometimes there's an exciting event too, right? A
Yes.
significant loss in the family or a significant
Sure.
tragedy that can kind of tip the scales, if you will.
Yeah, absolutely. Yeah. All right. So going into that first full-time role, you had a little bit of baseline going on, but you recognized you needed to really build that program and execute it through the whole system. What did you not know going into that you wish somebody had told you on day one, looking back?
I guess, I was hopefully optimistic, and I was like, I've had a bunch of success in my career and everything I try to do, I've done, at least in my opinion, well. I don't, maybe my bosses will tell you something else. But I guess if someone had told me how challenging it would be, I don't think that would have swayed me necessarily, but it might have prepared me a little bit more, because in my mind, this is a major issue and everybody should just understand that. And, we have a nationwide problem with the opioid epidemic and everything we can do to help that on our own end. All that is like just common sense to me, but it's amazing how many people put up, blockades and prevent these programs from progressing or from growing. Change is tough. Even good change is tough for anybody. So there's that factor alone is difficult, but then just trying to get people to buy in. And so I think, just preparing somebody if they're going to enter into this field for that challenge and make sure that they're ready to give everything to it,
Yeah, no, that makes sense. I was talking to somebody recently. I feel like drug diversion mitigation is one of those things that facilities almost feel like they can't even let out of the box to talk about it, because if they even bring up the discussion, then they have to recognize that, well, what do we do if we have an issue here or we find someone, they don't know how to tackle it, they're overwhelmed with it. And so it's like, let's just not talk about it. Let's pretend that it doesn't even exist.
Almost like the ignorance is bliss. And if, we don't want to speak it into existence, even though
Exactly.
You and I both know that it is occurring at probably every hospital in America. Let's be honest.
Yeah. Agree. So who were your first allies inside that first system that you worked with? How did you find them?
So going from a frontline, a bench pharmacist role to more of a leadership operations role was challenging at first. I had to learn how to collaborate with key stakeholders, if you will. So some of my allies, obviously pharmacy leadership is always a strong ally, but then, engaging with the C-suites, getting to know the chief medical officer, getting to know your chief nursing officer, even, high-level nursing directors are certainly important. And, I guess I say it was challenging, but on that level, it was a little bit easier to engage support because they are aware of the consequences. They're keeping up with the Becker's healthcare and all the articles that we're seeing, So I feel like those were the initial partners. And then as the program continued to grow, I guess cascading that down to more of the frontline supervisors or nursing managers or medical leaders was more of a challenge in that regard.
Sure. Yeah, it takes time. And when you're not used to running in those circles, to put yourself in positions where you can have access to them and start engaging in those relationship conversations.
I think
Very
that's
important.
key. I think relationship building, because as I was first going in, it was kind of like, who's this guy? He's a pharmacist. We don't know him, kind of thing.
Right.
But very, very quickly, you bring the data, you show the consequences, you show the why. I always start with the why every time I talk to anybody. Why is this important? What could potentially occur if we don't get a hold of this and do our due diligence in diversion prevention and detection?
Right. When we spoke previously, you mentioned that this hospital actually had a visit from the DEA 3 times. And what was interesting, I asked you, was it an event? And you said, no, it was routine. So you went through 3 of them as part of the DEA's routine inspection. So you've seen the process from the inside more than once. Walk us through what those visits actually look like for the hospital. What are the inspectors really focused on from your experience?
Sure. And I probably misspoke when we spoke last time. It was actually 3 separate visits at 2 separate hospitals. So one of our hospitals,
Gotcha.
One of our hospitals, they visited twice because we had 2 separate DEA registrations there. We had a regular hospital DEA registration and we had a narcotic treatment program registration, which that was a huge eye-opening experience because we were doing basically the same practices, yet those 2 registrations are relatively different. They have their own intricacies that I was previously, unfortunately ignorant of. And then the other hospital was another hospital registration. So it was, when I got into this, speaking with pharmacy leaders, medical leaders, everybody in the leadership team at the hospital, we're always afraid of that. We don't want that undue scrutiny. We don't want the DEA coming in, kicking down our doors and us being a headline on the front page news, such and such hospital cited for $2.3 million. We don't want that. And so most people that I talk to are aware of those headlines. So we want to do whatever we can do to prevent that. I mean, from, strictly a negative press and organizational reputation, stuff like that. So we had prepared, we had done a lot of work to grow the program. We were, one of the major things we did initially was establish a medication diversion committee or a drug diversion committee. And that was, an oversight committee with the C-suite leadership all the way up to the president of the hospital, where we not only had different things that we worked on as a group, but we also reported out different metrics, Pyxis inventory completion rate, stuff like that, on a regular basis, just so we can make sure that we're keeping an eye on stuff, discrepancy rates, stuff like that. So we had a lot built up and we felt pretty good. We're like, I've been doing this, I think it was about 2 years full time when the DEA knocked on our door. And I say that, we were hesitant and we were always apprehensive of that. And it was funny, my boss at the time, I believe it was Monday, right before lunchtime, he called me. I was in my office. He said, "Hey, Brennan, I got 2 DEA agents in my office." And we had a joking relationship. We were friendly. He was my boss, my direct boss. And I almost thought he was joking. And I was like, well, let me not say anything inappropriate here.
Just in case.
Thankfully, I didn't, because he actually did have 2 DEA inspectors. They were diversion inspectors in his office. And, they came in very unassuming. And there's a lot of different presentations out there that do probably a better job than I'll explain, but I'll give it to you from my perspective. They came in normal clothes. It wasn't like they had the blue jackets with the yellow letters on the backs and the guns and the tactical helmets, anything like that. They just came in like two normal investigators, and they were certainly very cordial, but they had a job to do, and they came in and asked, all right, well, this is what we're going to do. They laid it out. They laid out the steps for what's called an accountability audit. So they picked between 5 and 10. I think it was right around 7 items, and they really want to see from the cradle to the grave of those items. So when we ordered them, when we received them into our hospital, our pharmacy, to when they were ultimately disposed of or administered to patients. So all along that life cycle, if you will. And also they're asking about our policies, our how we do stuff, basically, what our security, how are we keeping stuff locked up, stuff like that. So I would never recommend it. It wasn't fun, but it was definitely eye-opening, and I learned a lot from it. And I learned that even though I thought we were doing a really good job, there was a lot of blind spots that we were missing. And thankfully, we were able to engage with them. And it certainly wasn't, collaborative like you and I are talking, but they were willing to educate, and they provided me with a lot of insight about what they're looking for, why they're looking for this, how this could relate to drug diversion, how this regulation, which when I read it, it seems very vague, but why it's important. And so I grew and I learned a lot from those 3 separate inspections.
Right. You talk about looking at 7 drugs from cradle to grave, and then your policies, and then what do you do to keep your stuff secure? It seems very basic that we should all be able to do that and to answer those questions, right? I mean, if you've got a program, then obviously you have policies. Obviously, you should be able to articulate how you keep things safe. And the other is just math. I mean, we're keeping records, so we should be able to do it. But it doesn't work that way, right?
No,
and so I'm curious on those meds, the 7 that they picked. Do you remember, were you able to account for all of them down to the very last one?
We were able to. We didn't get cited for any losses. I'll leave it at that. They did find some things that, like I said, we had blind spots to, and it was helpful. Even just understanding of the regulations. I'll give you a silly example. The biennial inventory. Taking the biennial inventory as it's written in the regulation versus the intention. The letter versus how we intended it were very different. We did a biennial. We actually did it every year instead of every 2 years per the regulation. But I kept a great Excel spreadsheet, and it was all organized, all beautiful, and you could literally reference any item in a second. It'd tell you where it was at that day and time. Well, that's out of regulations because
above and beyond, you would think.
It's way farther than, but it wasn't printed or typewritten. I don't know where you get a typewritten in this day and age. So that's actually a citation, that's out of regulation. So stuff like that. So we really, as a result of those inspections, I really dug deep into the regulations, and the DEA gives you everything you need for the most part. There's some open for interpretation things, but I got digging deep into the DEA pharmacist manual, which kind of outlines things that I'm like, wow, I was really not aware of that. I was really kind of, we're trying to do the best we could, but it was kind of out of regulations. One thing, I said they pick about 5 to 10 items, and one thing that was really tricky, and this is, and the regulations, I think when they were written, they were intended for retail pharmacies, a single operating area, whereas a hospital, one of my hospitals that was inspected, had over 60 Pyxis stations, 60 med dispensing cabinets. So stuff goes all over. And one of the items that they picked was oxycodone 5 milligrams, which is, arguably the number 1 used PO med in all of America, right? So can you imagine all the transactions to 60 different states, over 60 stations that occurred from the time that we had last counted it until the time that the DEA knocked on our door. I mean,
Yeah.
there was huge, tens of thousands of transactions. And so to try to account for each one was exceedingly difficult and certainly eye-opening.
Yeah. I mean, how did you find if the numbers were off, did you find, oh, we forgot to look here? Or, I mean, do you have any
One of
lessons learned from that?
Yeah, so there were a lot of different things. So like I said, we picked oxycodone 5 milligram tablets, and one of the practices at that current hospital was to split it into 2.5 milligram tablets, because that was the lower end of the pain scale order set. So if the patient had a moderate amount of pain, the general order set had 2.5 milligram tablets. So that in itself, it comes in from the wholesaler as Oxy 5, and then we're manipulating it, compounding it into 2.5. And so just in the compounding, we'd have losses, through the process, and then trying to account for it from then. And when it comes back, and it was very challenging. So if that is something that goes on in other institutions, just be aware that hopefully that's not one of the items they pick.
Which you could probably pretty much guarantee that they will.
Yes.
Right.
Yeah.
All right. So for anybody who's listening that's never been through a DEA inspection, are there things that you would tell them to maybe stop focusing on so much, or maybe it's just make sure you're actually focusing on this as a priority?
Well, I think a little bit of both, because, when I was initially growing the diversion prevention program, we were heavily focused on detection. So we're trying to find who's taking the drugs, where are they taking them, how are they taking them, detecting. And so we, as a result of that occupied, we had one FTE, me, doing it for 3 hospitals. So that occupied the bulk of my time doing audits, doing, looking for where stuff could potentially be missing, tracking down documentation discrepancy, which by and large, let's be honest, those are honest mistakes. If you have a pattern of dozens, but I mean, if a person misses, a waste documentation, or forgets to document the administration, but does document the waste, then generally they just forgot to document it. Or we've seen technology errors where sometimes it scans, but then the server times out, or, different things that can honestly explain for why that wasn't. And so we were focused so heavily on that, so heavily on the audit, especially high risk areas like endoscopy, our cath lab, stuff like that. And those are kind of the low hanging fruit, if you will. When you read like the ASHP guidelines, they talk about make sure you have a program to audit, the high risk areas, the pharmacy,
Right.
the peri-op areas, the procedural areas. So we're like, all right, we're going to focus on that, and we're going to spend like 95% of our time. Whereas, a lot of the things that we were cited for, that we were found to be doing inaccurately, were regulation based, and there were record keeping violations or potential security violations, or just a misunderstanding of the whole rationale for doing it. And I'll give you one example of that. We had, our reverse distributor, our stuff that was packaged up by our reverse distributor and getting ready to be sent back to be destroyed. Most hospitals have that process. We were considering that as soon as the reverse distributor came in, processed it all, put the C2s on the 222, put the 3 through 5s on the invoice, and then handed the box to us. We were like, okay, that's your problem. That's basically garbage, right? It's getting sent to a factory to be destroyed in Texas. So we're not worried about that anymore. We're just going to leave that, we'll leave it on the pharmacy director's office, desk. We'll leave it there, and then we'll take it when we can, no big deal. Well, when they came in and identified that we were doing that, they're like, no, that is your problem until it arrives to another registrant, another DEA registrant. And that was an eye-opening experience. And that could have been super problematic because, these boxes contain, tens of hundreds of different doses. And it was on us to deliver it to the UPS or the FedEx or whoever was sending it. And we did not even consider the fact that, hey, that could get stolen before it gets shipped out, and we have no accountability for it. So that was just a a complete blind spot that caught us super by surprise.
Yeah. Did they spend much time even talking about after it gets out of pharmacy, the things you were focused on in terms of, endoscopy that you mentioned and making sure nothing was missing there? Obviously, in the inventory reconciliation piece, they would have picked up on something if something just disappeared.
Mm.
But as far as the monitoring piece of the diversion program, did they even go in that direction, or was it all focused on what's happening in the pharmacy with paperwork, documentation, and the numbers?
Yeah, and that's generally it. If it left the pharmacy and didn't make it to the Pyxis station, for instance, that would be a break in the chain of custody, and that it would have been focused on there. But a lot of the audit was focused on only up until it was either dispensed to the patient or wasted or returned to the pharmacy to be sent back to the wholesaler. So that was pretty eye-opening to me, because we were kind of focusing on after that fact, from dispense to the patient, that documentation and stuff. And we weren't focusing so much on the precursor to that. Does that make sense?
Right. Yeah, no, I think it makes sense. And I think the way I look at it is if you have an event, right? So if you're not focused on those things, how do you keep your patients safe? How do you keep your employees from accessing and taking and diverting? Then the likelihood that you'll have a significant event becomes higher, right? And
Yeah.
then there's a problem and the DEA finds out about it, and then they come in because of that. But then when they come in, it seems their focus is, well, how did you let this happen? And it all goes back to now your paperwork and your accountability and the things that you've already mentioned that they looked at. And then that's their focus when they come in. And if they find gaps, it's like, well, these types of gaps are what allowed this to happen. And so this is where you were, quote unquote, negligent, or whatever the word is that they would use.
Yep. And that speaks to a good point too. What is the nature of the visit? So thankfully we didn't have a reactive visit, a reactionary visit, if you will. We didn't have, unfortunately, someone found overdosed in the bathroom or something, some terrible scenario like that. These were part of from the best of my understanding, of course, they're not going to tell me as a non-DEA person, but from the best of my understanding, these were routine inspections, part of the DEA cyclic inspection work plan, thankfully. And I guess, and also I've learned I have retired friends in the DEA, and I've also made acquaintances with active DEA people. But I've learned there's two different arms too. There's the diversion investigation arm, and then there's the law enforcement arm, which is, the agents versus the investigators. And they're all DEA, but they're two separate areas. So thankfully we had the benefit of working with the diversion investigators and not the law enforcement arm, which could have been a lot worse, as you talk about, with, reactionary audits.
Yeah, I think the bottom line is facilities have to do both, right?
Yes.
But they probably don't spend enough time looking at those CFRs and really drilling. It's like you need a lawyer's eye to read every single one of those words and go through it, and make sure you're completely compliant, and then make sure that you mitigate that risk for a diversion, because either way they're going to come in. And they could come in as a routine, and then they could come in because of an event, but they're still going to look at that pharmacy and see what's going on in there. So you got to do both.
Absolutely.
The chicken or the egg, right? You got to be ready for both. So now at your current hospital,
Yep.
You were hired. Well, correct me if I'm wrong. Were you hired to develop a program, or did they already have something in place before you got there?
So they had they had something in place historically. It was a risk-driven program, and they've done great work through the years. But they brought me in to lead it more from a pharmacy perspective, because a lot of those CFRs, like I mentioned, we're seeing that either unawareness or basically unawareness. People were just unaware that, oh well, if we have a theft or a potential loss, there are reporting requirements, not only to the DEA, but also to the state Board of Pharmacy and whatnot. So to guide that process, that's how I came into this role, my current role with ECU Health.
Okay. And are you running the same playbook that you learned at your previous, or are you doing things differently based on what you learned the first time around?
Well, it's two very different environments, so I can't run the same playbook. It's New England versus North Carolina are two very much different. Love it in Eastern North Carolina, by the way. Don't let me dissuade anybody, but so it's different. But I mean, a lot of the same themes are there. It's all about relationship building. It's all about engaging key stakeholders. It's education is huge. Getting that education from the president all the way down to the frontline worker, all the way to EVS, honestly, to everybody in the health system. We want to know, or at least to have a baseline awareness that, hey, if you found a syringe on the ground, that, on the way to the cafeteria, then everybody should be empowered to report that. So that's been my challenge lately, is just, trying to get more awareness and build that baseline knowledge across the health system.
Right. Is there a piece that you underinvested in last time that now you're prioritizing earlier now with this current facility?
I think kind of like what we talked about, not so much focusing on the detection, more focusing on the prevention. And also at the end of the day, one thing that we've been working on really, really significantly is destigmatizing the diversion issue. At the end of the day, we're all healthcare workers, and we want to get our colleagues or anybody who's afflicted by this the help that they need. And, if they are suffering with substance use disorder, we want to get them the help. And we're not saying that you might be able to keep your job after if there's something that's going on, but we want to make sure that you get the help, because I personally have worked with nurses, when I was a bench pharmacist, and one of them was involved with a significant diversion event. She was terminated after multiple attempts of trying to get her the help she needed. She was terminated, and then about a month later, she committed suicide. And this was a mother of two, leaving two relatively young children motherless because of this terrible, terrible condition that a lot of us are dealing with. Not us, I'm sorry. A lot of people in America are dealing with.
Right.
So that's one big thing, trying to get the prevention out there. And, just because we have to talk to you about potential practice concerns doesn't mean that we're implying that you're out there stealing narcotics or doing something nefarious. Sometimes it is just that, a practice concern, but we want to make sure we're all operating in the eyes of patient safety before we assume anything worse. Right.
In the case of that previous colleague that you were talking about, do you think there's something that could have been done differently that you're bringing to the new program?
I think about that a lot because, as an overnight pharmacist, I was involved, and they came to me and asked me, are you noticing any behavioral trends or anything? And absolutely. I tell everybody, I use this when I talk to a lot of people, so I apologize if anybody else has heard me speak about this, but this was a nurse that was hot and cold on a good day. One day I would come up to the unit and she would absolutely wrap her arms around me and I miss you, Brennan. I love you. And I'm like, well, that's a little weird. And then other days, well, we didn't have an outside relationship,
Yeah.
But other days I'd come up to the unit and it would be like a pit bull, and she'd be like scowling at the desk, and so I was like, absolutely.
Not as weird, but very rude.
Yeah, exactly. This is the same person that was hugging me yesterday. Like, what is going on here? So, there was obvious behavioral issues, patient complaints, other coworker complaints, so I think about that, and we tried, I wasn't directly involved. The nursing leaders tried to get her the help. They even did a 4-cause drug screening, which she passed, which was news to all of us. And there was multiple attempts, multiple interviews, denial. And eventually what actually did her in, what actually got her terminated, believe it or not, was she was driving to work impaired one night and was pulled over by the police officer, and they searched, they identified that she was impaired, searched her car and found a bag full of stolen narcotics, presumably stolen from the hospital. Pharmaceutical grade narcotics, not illicit fentanyl.
Yeah.
This is before illicit.
Yeah.
This is many years ago.
Yeah.
And that's why, she was arrested and charged, and as a result of that, the organization was able to terminate her. But like I said, if we could have gotten her the help before that, then maybe it would have had a better outcome, definitely for her children.
Interesting. I mean, that would be an interesting case study, because if they were that involved, you saw the behavioral things, everybody saw it, complaints, you said multiple interviews, drug screen. I mean, so much went wrong there. Like
Yes.
how, yeah, just
the old Swiss cheese theory, right? The holes line up and just, multiple things. And I think about that often when I'm making changes or proposing changes in my own diversion prevention program. What can we do better to avoid that? And, one of the challenges, and I've had this historically, is I'm a pharmacist. I'm not a law enforcement officer. I'm a healthcare professional. So I don't want to come off as a law enforcement officer and just kind of shut down people. I've been working hard at trying to get people that we're interviewing to open up and to admit and get that help that they need in a timely fashion before a terrible outcome like that happens, or even as bad if a bad patient outcome happens as a result of an impaired healthcare worker. So that's one of the challenges that me and I work closely with our risk team. I work, multidisciplinary committee, work with all sorts of different disciplines, but most closely with the risk team at ECU Health. And we've been working a lot on that, trying to improve that.
Sure. And along these lines, a diversion program really relies heavily on whether frontline clinicians see it as something that is done with them as opposed to them, right? And nursing and anesthesia are right at the center of that, anesthesia being a particularly high-risk area. So how have you gone about getting nursing and anesthesia to come alongside as partners and see it more as surveillance and safety than gotcha?
Yeah, and that's a huge thing. I briefly touched on it before about education, just trying to get everybody on board. And, we've had so many instances, not at ECU Health per se, but just throughout my career where, we knew something was wrong with that person, but I didn't want to get them in trouble, or I didn't want to rat them out, and well, I'll tell you what, I would rather have that uncomfortable conversation than go to their funeral. And that's what I tell everybody, that, this isn't just another thing. This is also part of your job. You care for people, right? Nurses, anesthesia, they care for people. Well, let's care for each other. Let's care for your colleagues. Let's care for somebody, even if someone's having a bad day, let's figure that out. A lot of times it's not diversion related or substance use disorder related. But we should care for each other and try to figure that out. And if there is something going on, the sooner we identify that issue, the better the outcome is going to be for everybody.
Right. And you've got that experience too, that I'm sure you share and you can draw on. So it becomes more of a real, it's not just theoretical.
Right. It's not just Brennan up here saying, we need to do this because, I try to explain that there's an important why, because we're doing this. It's not just leadership telling you, you need to do this, or, you need to, and, it is, people are trusting and people don't want to have difficult conversations, but sometimes, that needs to happen,
Yeah. So if there's a hospital leader listening right now that realizes they don't have a real solid program, what is the first step you would tell them to take Monday morning?
There's a couple steps. I would say hire a good pharmacist that can lead your program. But not that I'm in the market. I love my job, like I said. But the other opportunity, because I say that in joke, because I know trying to get a new FTE approved at a health system is like an act of Congress these days, for the last 10 years or so. But
Yeah.
The other option is there are a lot of really good consulting groups. I think you might know something about that, Terry. But
Yeah.
I haven't had the pleasure of working with you outside of this, but I know I've heard and I know other consulting groups. So at least to go in and do a baseline assessment, kind of find out where, that gap analysis, kind of find out what you're doing currently, because a lot of hospital leaders don't know, are we doing anything? Are we verifying what's coming in was what was ordered? I mean, that's the procurement audit. That's the simplest way to divert, right? We got a pharmacy tech that's in charge of ordering and receiving. And instead of receiving it into the pharmacy, they're receiving it into the back of their truck. And, I mean, that's where we're seeing massive diversion events, across the nation. And that's such a simple thing to reconcile. That's 2 Excel spreadsheets if you don't have any other technology.
Yeah.
So find out what you're currently doing. If you're doing anything, find out what you need to be doing, and find out how you get to that. How you get to that completion status.
Right. And just start one step at a time.
Yeah.
Yeah. Okay, great. Well, thank you very much. This was really informative. I think it's going to be good information for the listeners, and they'll get a lot out of it. So thank you very much, Brennan.
Thanks for having me. Appreciate talking with you.
Absolutely. Enjoyed it myself.
Thanks.